Rennie for the invitation. This is the main problem is post-operative IOL refractive surprises. So there are a lot of things and discussion comes. It's avoidable, unavoidable. That's the question. When it's a medical legal or in a clinical practice, it is unavoidable. It will happen to everyone. It will happen. It only depends upon the number of cases you do it and the number of surgeries you do it, how is set up. It's an unavoidable complication like PCR or nucleus drop. Once in a while, it happens. So you cannot argue that's an avoidable complication. So what are the reasons? That's the one we have to see that we can analyze only post-operatively. What went wrong in that particular case and where. So with the modern scan, everything, once we used to think that the axial length measurements are wrong in our days, but with optical biometers, the axial length measurements are good. Now we realize that keratometry is wrong. So once keratometry is finalized with multiple instruments, then we are saying the formulas are wrong. There are 100 formulas at least existing that itself shows that this unavoidable complication is going to happen because there are so many formulas are available now. You read every conference you go to, they will tell multiple formulas for each one. So in this particular case, I will show you same patient. We took two different times of the time scan. And axial length is the same. K readings, you see that's a lot of difference between the two, almost 0.75 diopters. So it is going to reflect 0.75 diopter post-operatively. So that's what we found. Most of the times it's a K reading nowadays going wrong, not the axial length. So even with the A scan, ultrasound also, it's the same thing, but we are wrongly attributing at that time. So once we realize the reasons, the other things where we should be careful. Post-refractive laser surgery, high myopia, high hypermetropia, which doesn't fit in the normal Bell's curve. Within the 60% is okay. 20% this way or that way, they are going to go wrong in some way. Short axial length, flat cornea, long axial length with a steep cornea, and long axial length myopia, we expect a flat cornea. If you have a steep cornea, you are going to go wrong, pre-operatively. Same way, the short axial length with a flat cornea, the formulas doesn't work. Then once it has happened, only thing the problem is the problem. But don't show anxiety. There's nothing a problem. You have to just be cool and say it's going to happen once in a while. It's okay. So I can handle it. That's where you have to. You should not. All the staff you have to orient. You should not tell them that they should not show a refractionist all. If they show anxiety, then you are getting killed. So then we have to find where the problem has happened, then how to solve it. So there is a problem solving solution, looking at the results together. These are all we have to do it, not the patient sitting there. You have to send the patient home and you work it leisurely, woeful. So it's a question of monofocal, multifocal or toric lens. Which lens has gone wrong? So monofocal, multifocal, commonest problem is the pre-LASIK or pre-PRK. We have a lot of formulas. For pre-LASIK, if you go to ACR's website, there are 16 formulas. All 16 give 16 different results. They don't give, very rarely two of them will match. So naturally, one we have to trust and we have to put it. So one, that's going to be a problem. So you should not get worried. So generally we avoid multifocal in these patients because the results are not very accurate in this post-laser. Then in toric lenses, most of the times we saw is axis wrong only. So if you have a quite different place, you have some place to patients wait for some time, keep the toric patients for 2 hours and see post-operatively. If the axis is not good, rotate and send them in the same day. If the patient goes home, then comes back and then we can tell them the axis has rotated your special lens, we have to redeal it. Then the other choice, if the patient comes after 2 or 3 years, it's difficult to rotate these hydrophobic lenses, then we go for a best corrected vision and we go for LASIK. Very rarely we go for IOL exchange. So for how do you fix it? The astigmatism, if the patient comes after a week or 10 days of toric, it's not working well. Generally I take K readings again, that K readings I will match it, then I will cross verify with the astigmatismfix.com, it works very well. For example, this is common. I don't say it's unusual. I do once in a year at least this problem. I put in the opposite axis. If the patient is, I have to put it 90 degrees, somehow by some overthought, I will put in the 90 instead of, this is a 15 days post-operative. I have to put it in 20 degrees, I put it in 70 degrees. So we are just take the patient to the theater, 10 minutes, you rotate it and send it. Some US, I saw some people, here what you have to do is even 15 days, you have to rotate, not one, you have to rotate in both the directions. If you put in one, you can put this zonal dialysis. So monofocal, my preferred choice is the LASIK because I have a LASIK machine. If you don't have a LASIK machine, that's the problem. So then you have to go most of the times IOL exchange or a piggyback lens. So simple, LASIK is a simple answer. One diopter, 1.5 diopter, there is no point in doing IOL exchange. So LASIK is there, but disadvantage is non-availability. If you are not having nearby, your friend, one of them is there within 10 kilometers, I advise them talk with him and send for LASIK. And if the range is large, like +4, -9, it happened to me. So one patient, 3, okay, -3. So I put one eye -3. Second patient, when the second eye came, they gave me 3. So +3 they gave. It's a -3 lens. One eye I put -3, the other eye I put +3. The patient is supposed to receive -3 both the eyes. So patient landed with -4 diopters myopia. So these things will happen. The IOL exchange is a simple answer for that, but we have to find out where it has gone wrong, whether it's the entry or biometry. What is the new IOL power? This IOL cutter is working very well. This I'm not doing, but my colleague is doing nowadays. This is working very well. It's cutting like a butter. Instead of pulling, pushing lenses, cutting with the scissors, it makes you can make 3-4 pieces if you are patient enough. And each piece you can remove with the 2.5 mm incision easily. You can pull it off. You can cut into linear lines and take it off and put a new lens. But this you can do it if it's all happens within a period of 1 month. If it's more than 3-4 months, then it's an issue. The capsular integrity may not be good to put the lens back in the sulcus and the bag, capsular bag. The other is piggyback. This is the simplest answer. We didn't have because Raynar is very expensive. Now we have IOCare. The IOCare lenses are quite not that expensive, but you have to pay from your pocket. It's once in a while. You don't do it every day, once in a year. Okay, let it go. Don't worry about the money. Buy a lens and put it. You can correct both toric, spherical, all the things, and patient will be quite happy. So in my practice, I mostly perform LASIK. IOL exchange is my very rare, and piggyback I have done few times. Thank you very much.
Thank you, sir. I'll invite Piyush for his talk, and if you have time, we'll have discussions. So if you send the patient for LASIK, who pays?
Some they send, other doctors they send. Some they say they counsel the patient, you pay something, you have to pay, and they pay. Some they say, some doctor they send, you do it, I will pay, they will pay. And sometimes they request that don't charge the patient. Once in a while, some doctor will ask, anything we oblige, anything, it's no questions. It's a question of integrity of the eye care delivery system in the society. It is not the integrity of you or me. If the patient lose trust, they are going to lose trust on every eye surgeon in India. So we have to maintain that first. Then comes integrity of you.